Okay, this will be a general overview of MRI evaluation of the knee. This is by no means comprehensive and should definitely be used in conjunction with available textbooks as well as the large amount of resource material available online. We're going to cover some of the main things that are evaluated with MRI: the ligaments of the knee, medial and lateral menisci, large tendons, common bursal abnormalities, as well as fat pads. Starting with ligaments. On the medial side, the main supporting ligament is the medial collateral ligament. On the lateral side, we have the lateral collateral ligament complex, made up of the iliotibial band, the fibular collateral ligament, and the biceps femoris primarily. The stabilizing ligaments in the anterior and posterior dimension are the anterior cruciate ligament and the posterior cruciate ligament. Here's an MR coronal image showing the medial collateral ligament. It is a ligament that extends from the distal femur to the proximal tibia on the medial side, obviously. You can see that the tendon is smooth, regular, low in signal, and without significant thickening. Abnormalities you can see involving the medial collateral ligament follow a similar pattern of ligamentous abnormalities you can see elsewhere. Low-grade tears of the medial collateral ligament generally show edema overlying or superficial or medial to the medial collateral ligament. Moving up to higher grade, you have edema actually within the ligament with thinning of the ligament or partial tear. Grade 3 or high grade, you have a complete ligament rupture. The images on the left here with the yellow arrows show abnormal increased signal as well as thickening of the ligament, and you have edema and fascial fluid overlying the ligament in a partial tear. The image on the right shows abnormal laxity as well as complete discontinuity of the distal aspect of the ligament, which you can see on the lower part of the image. Along the lateral aspect of the knee, we have the lateral collateral ligament complex. Going from anterior to posterior, we have the iliotibial band, which inserts on the tibia. We have the fibular collateral ligament, which inserts on the fibular head. And we have the biceps femoris, which also inserts on the fibular head. An important abnormality to be aware of involving the lateral collateral ligament complex and posterior lateral aspect of the knee is an entity called posterior lateral corner syndrome. This is something that is seen with trauma and involves three main abnormalities. One is a rupture of one of the components of the lateral collateral ligament complex, being the iliotibial band, biceps femoris, or fibular collateral ligament, as well as a ruptured popliteus tendon, arcuate ligament, or popliteofibular ligament. Now, these are smaller ligaments that can be hard to see, but usually manifest with ill-defined abnormal signal diffusely in the region where you'd expect to see these ligaments in the posterior lateral corner of the knee. In addition to these two, you also will have a ruptured anterior or posterior cruciate ligament. When you see one of each of these three abnormalities, you want to think about posterior lateral corner syndrome. It's considered a near emergency and should be operated sooner rather than later. These are usually associated with an avulsion, fracture, or significant edema of the fibular head. Here's showing the torn ligaments there of the lateral collateral ligament. The image on the right is showing a significant edema of the fibular head. Moving on to the anterior and posterior cruciate ligaments. The anterior cruciate ligament extends from the posterior femur to the anterior tibial plateau. It prevents abnormal anterior dislocation or anterior movement of the tibia. As you can see, it's a fairly taut or stretched ligament, which is important because when the ligament tears, you have retraction of the fibers, which prevents normal healing. Here are two examples of abnormality involving the anterior cruciate ligament. The image on the left showing abnormal increased signal and ill definition of the fibers, as well as you have a little bit of laxity of the fibers. The image on the right shows a complete discontinuity of the fibers. If you were to scroll through these images, you would see that you could not make out the fibers from origin to insertion. Here is a normal appearance of the posterior cruciate ligament. There is generally some laxity of the posterior cruciate ligament. It is diffusely low in signal and generally fairly thick, as you can see here. Here is a complete tear of the posterior cruciate ligament. We have abnormal signal in the ligament as well as a complete discontinuity at the mid portion with some adjacent edema. Moving on to the menisci, you obviously have two menisci, one in the medial compartment, one in the lateral compartment. They are C-shaped and fibrocartilaginous. As viewed on the sagittal images, these show what's known as a bow tie morphology. This arises from the large anterior horn, the large posterior horn, and the relatively small body as viewed on the sagittal images. This bow tie morphology should be seen on two slices, which is important. If you see it on only one slice, it can be telling you that there's some kind of tear, typically involving the body. And if you see it on more than two slices, on three or more, you want to evaluate it on the coronal images and see if there's something called a discoid meniscus, which is an abnormal elongation of the body of the meniscus. Here's a sagittal intermediate weighted MR image showing the lateral meniscus. You can see the body is much smaller than the anterior and posterior horns. In addition, the anterior and posterior horns of the lateral meniscus are relatively equal in bulk or morphology. The medial meniscus typically shows slightly larger morphology of the posterior horn relative to the anterior horn, but otherwise shows similar morphology to the medial meniscus. Here's another image of the lateral meniscus in a more fluid-weighted, fat-saturated image. Moving on to meniscal tears, there's a variety of abnormal tears that you can get involving the menisci, which are easier to understand when you're looking at them in a presentation and sometimes can be a little bit tricky when you're actually viewing an MR study in real time. The main categories are considered horizontal, longitudinal or longitudinal vertical, radial, oblique, and complex. Here's a diagram showing the different types of tears. The first is a vertical longitudinal component. Now, the longitudinal descriptor basically means that the tear follows the long axis or the curvilinear axis of the meniscus. So you can see that this tear would be longitudinal, this tear here would be longitudinal, this would have some longitudinal component as well as this one here, whereas this is perpendicular to the curvilinear axis of the meniscus. So we'll go into some more detail on these different tears. The most common type of tear that you'll see is a horizontal tear or a horizontal longitudinal tear. This is a tear that is parallel to the tibial plateau, meaning that if you were to cut it with a knife, your knife would be horizontal and your knife cutting through the meniscus would be parallel to the tibial plateau. It typically separates the meniscus into upper and lower parts. We have a sagittal image on the left and a coronal image on the right. You can see this horizontally oriented longitudinal tear separating the meniscus into upper and lower parts. Here is a vertical longitudinal tear. Again, this longitudinal tear following the long axis or the curvilinear axis of the meniscus. However, the tear, instead of having that knife in the horizontal dimension, the knife is actually in an upright or vertical dimension. As you see on the image on the right, the tear is oriented vertically, and if you were to scroll through multiple images, you would see the longitudinal component. This is an example of a radial tear. This is a type of tear that extends perpendicular to the axis of the meniscus. You can see the image on the right showing a fairly large radial tear, and in this case possibly complete full thickness through the meniscus, but it's not extending longitudinally. Here's an oblique or parrot beak tear. This shows features of both radial as well as vertical longitudinal tears, meaning that it starts in a radial component but then extends longitudinally. These are typically show a vertical component. Again, another diagram and image here. The image on the right is an axial image showing that initially on the diagram on the left you can see it starts in a radial manner and then extends to have a longitudinal component. A complex tear is considered unstable, can be associated with a meniscal fragment, significant irregularity, meaning there's tears moving in more than one dimension. Sometimes it can almost look like a comminuted fracture, or a tear that extends for a length of 10 millimeters. You could describe as complex. A bucket handle tear is an abnormality that's superimposed on a tear that's already existing, meaning that there's already a longitudinal tear present. However, this tear becomes partially flipped, meaning that the anterior and posterior components remain intact, but the main portion of the body of the tear gets flipped over, usually into the medial or central aspect of the joint space. The arrows here are pointing to an abnormal meniscus. The image on the right shows the region of the expected part of the body. The image on the left with that long arrow showing that there's a large meniscal fragment that has been displaced, and the arrowhead is indicating there is absent body where you would expect it. So this is a case of flipped meniscal fragment or meniscal bucket handle tear. This is a flap tear, meaning that there's kind of a delamination or a tear involving only one side, maybe the undersurface or the superior surface of the meniscus, that becomes flipped and does not extend all the way through the meniscus itself. Image on the left here, the arrow is pointing at the flap, which has been displaced inferior to the body of the meniscus. The sagittal image on the right is showing similar finding. Moving on to tendons. As evaluated on the sagittal images, we have the quadriceps and patellar tendons. The patellar tendon is a misnomer. It's actually a ligament extending from the patella to the tibial tuberosity, but we refer to it as a tendon. These tendons should be homogeneous and low in signal. There can be a little bit of normal fibrillation at the distal quadriceps tendon, but the patellar tendon should be homogeneously low in signal. Moving on to some abnormalities we see of these tendons, predominantly involving the patellar tendon. The first entity we'll discuss is called jumper's knee. This is a degeneration or partial tearing of the patellar tendon. You can see this in athletes, patients with rheumatoid arthritis, and other seronegative or non-rheumatoid arthritides. This sagittal fat-saturated fluid-sensitive sequence is showing that there is diffuse thickening and abnormal increased signal of the patellar tendon, most prominently proximally, and it's important to note that the patella shows normal signal and normal cortication at the inferior pole of the patella, jumper's knee. An abnormality involving the distal patellar tendon, something that we've all learned at some point during medical school. Osgood-Schlatters disease. This is a traction apophysitis, meaning that it's involving the apophysis at the tibial tuberosity. Seen most commonly in athletic adolescent males. Cyclical pain, swelling over the tibial tuberosity, non-operative treatment. Here we see abnormal increased signal, thickening, but this is Osgood-Schlatters disease. You can kind of think of this as the opposite of Osgood-Schlatters, meaning that it occurs at the proximal patellar tendon. An entity called Sinding-Larsen-Johansson syndrome. This is a chronic avulsion or repetitive microtrauma involving the inferior pole of the patella. In this case, you see there's abnormality of the patellar tendon as well as the inferior pole of the patella, showing some fragmentation and edema at this level. It's important to differentiate this from a patellar fracture. Those are usually more proximal or involving the junction of the body and inferior pole of the patella, but it's going to look a lot different. It's going to involve much more of the patella itself rather than just the inferior pole. Patellar tendon lateral femoral condyle friction syndrome. This is basically the patella when the knee goes from flexion to extension in normal movement. The patella and the patellar tendon are not tracking exactly where they should, and they kind of give rise to an edema. This is an overuse abnormality. You get abnormal signal at the lateral infrapatellar fat pad just below the inferior pole of the patella. We have two axial images here. The arrowhead is pointing at the proximal patellar tendon, so we're at a level just inferior to the patella here. The arrow is pointing to abnormal signal at the fat pad. You can see right there between the patellar tendon and the lateral femoral condyle, hence the name patellar tendon lateral femoral condyle friction syndrome. Here it is on a sagittal image. A little bit hard to orient yourself, but knowing what syndrome we're talking about, you can see the abnormality there. Patellar dislocation gives rise to a common pattern of kissing contusions involving the medial patella and the lateral femoral condyle, often associated with abnormality of the medial patellofemoral ligament. Basically, when the patella shifts laterally, that medial side is going to be the one that's stretched and either partially torn or completely torn. A lot of times this can be associated with patellar cartilage defects, so make sure you watch out for that. Here's an axial fat-saturated, fluid-sensitive image showing the medial aspect of the patella, showing edema, and the lateral femoral condyle showing moderate edema, as well as a joint effusion in this case. Here's another image of the same process. The edema is not as great here, but in this case we have a defect of the cartilage at the patellar apex. It's a full thickness defect, and the arrow is pointing to that displaced cartilage fragment. You can see here there's also a fluid level, indicating that there is a lipohemarthrosis, which should indicate you to search for a fracture elsewhere. Moving on to bursa, common abnormalities involving the bursa of the knee. Probably the most common was a popliteal cyst or a Baker's cyst. This occurs between the medial head of the gastrocnemius and the semimembranosus tendon. This can give rise to symptoms based on a large size or rupture into the soft tissues. It can mimic DVT. In fact, we often see these as incidental findings in DVT studies. Here's an axial image showing a well-circumscribed, simple fluid collection originating in between the semimembranosus and the medial gastrocnemius. Here it is seen in a sagittal image, tracking superiorly and inferiorly as they tend to do. Prepatellar bursa, this is an abnormality from repetitive trauma. Involves a bursa anterior to the knee. Pes anserinus bursitis. The pes anserinus bursa is located at the conjoined tendon insertion on the medial tibia. Tendons involved are the sartorius, gracilis, and semitendinosus. You can see here over the medial aspect of the knee there is a fluid collection not associated with an abnormality of the medial collateral ligament. As you can see there, it's thin and not significantly abnormal. Moving on to cartilage abnormalities. As far as cartilage grading systems, I'm going to include a quote here from the musculoskeletal MRI Helms textbook. We do not recommend a description of the cartilage using a grading system except for research papers. A simple description of the abnormality allows anyone who desires to place the lesion in his or her particular grading scale. Basically meaning that what you should learn is the abnormalities that are important to the different types of grading systems. Use them, describe the abnormalities with these terms, and let the person who is reading your report decide which grading system to use. Cartilage abnormality, chondromalacia. Chondromalacia meaning abnormal softening of the cartilage, typically used to describe the patellar cartilage in the entity you've probably heard called chondromalacia patella. As you get softening, you get abnormal focal signal in the cartilage. You can have partial thickness defects, you can have full thickness defects, you can have fissuring in the cartilage, you can have fibrillation in the cartilage, you can have delamination tears, and you need to describe the presence or absence of subchondral edema. Here's an axial image showing the patella. The patellar cartilage is thick, homogeneous in signal. The cartilage of the patella is the thickest hyaline cartilage in the body, so keep that in mind when trying to assess for the cartilage thickness. At the medial and lateral compartments, it's generally thought of as the weight-bearing and non-weight-bearing cartilage. You can see the yellow line indicating the weight-bearing and the red lines indicating the anterior and posterior non-weight-bearing cartilage of the femoral condyle. Here's a cartilage defect involving the patellar apex. You can see this is a superficial defect or surface irregularity, and there's no subchondral edema. Moving forward, here is a cartilage defect that is partial thickness, a little bit more than 50%, but I would probably just call this a near 50% partial thickness defect involving the patellar cartilage. Here's an image showing cartilage fissuring. These are partial thickness cartilage fissures as opposed to full thickness cartilage fissures, which you can also see. Here's a full thickness defect of the patellar cartilage. you can see that the black line that remains is the patellar cortex. Here's what's known as a delamination defect. You can see here that there is preservation of cartilage thickness, but there is a line of fluid here in between the cartilage and the cortex of the patella. This arises from usually shearing traumatic forces which shear the cartilage off of the cortex itself. You can see these, sometimes they convert to a flap morphology, in which case there would be a fluid cleft that would extend into a defect here and then along the cortex here. You can refer to those as flap tears. With cartilage abnormalities, you can have acute or traumatic cartilage defects as well as chronic or degenerative or osteoarthritis related cartilage defects. With acute cartilage defects, they tend to be well defined at weight-bearing surfaces and be more likely to have underlying subchondral edema. You can also have a displaced fragment. Here we have a well-defined cartilage defect showing a perpendicular cleft with respect to the normal cartilage. This is an acute cartilage defect, and that is in opposition, contradistinction to the wide and shallow margins seen on a cartilage defect based that is secondary to arthritis or degenerative change. This is also seen on weight-bearing surfaces, and you're also usually going to see other findings of arthritis such as joint space narrowing, marginal osteophyte formation, etc. I hope you found this material beneficial. Again, by no means is this comprehensive. I definitely recommend you to refer to as many resources as you can find. I'm going to leave these images up for a little bit so you can see the references. Some of these were used for content and some of these were used for images. Thanks for watching.